Most patients and athletes present with straightforward complaints. Clinical exam is easy, and the diagnosis is made based on their mechanism of injury, physical exam, and to some degree age. I'm Mary Lloyd Ireland. I practice at the University of Kentucky in Lexington, Kentucky. I'm going to share with you some conditions that I've seen over my career and ones that aren't what they seem about the shoulder. 31-year-old female lawyer, had had shoulder pain for a couple of years. She had classic signs and symptoms of a partial bursal-sided rotator cuff tear and subacromial bursitis and impingement. I had not gotten an x-ray in a year, so I did decide to get an x-ray. And when we look at x-rays, we need to critically look at all parts of the x-ray. If you look at the coracoid, here there is an expansile lucency in the coracoid. The distal clavicle looks fine, the acromion looks fine, and she truly did have an impingement, but the impingement was more coracoid impingement because of her mass in the coracoid. You can also see it pretty well on the axillary lateral view. You can see how the base of the coracoid is very expanded and looks abnormal. So you would think a space-occupying lesion of the coracoid might be a cyst, but this was actually a very low-grade chondrosarcoma. So these cases are not to make you paranoid, but to tell you to look critically at each x-ray, compare them to previous x-rays, have good quality x-rays, look at the x-rays yourself if you're going to be the surgeon, and get an x-ray within a year of the last x-ray. If the patient has not wanted to have surgery done for some reason, get follow-up plain x-rays. Here's her scan. You can see again an expansile lesion of the coracoid. See it much better on this scan. And her excisional biopsy, chondrosarcoma, grade 1. This is a 22-year-old left-hand dominant male who had a history of multiple osteochondromas. His girlfriend noted that there was some difference in the appearance of his scapula when she looked at him from the back, with the left one being a lot more prominent. If you look at his AP view and other views, you can see a scapular lesion. Remember, the scapula is very thin bone, the lesion with surrounding radiolucency. It looks like it's just sitting there, doesn't look particularly aggressive or permeative. This is the axillary lateral view. You can see the lesion. Scapula is here, lesion between the ribs and the scapula, emanating from the scapula. And then on this transscapular view, you can well see this space-occupying lesion, certainly a reason to have scapular winging mechanically. "3D CT scan shows the lesion very well. Again, the underlying or the surrounding scapula looks pretty normal. Since this was a central osteochondroma, suggestion was made to do an excisional biopsy, and this is what was done by the orthopedist who specializes in oncology and oncologic surgery. This right-hand dominant 18-year-old college student was doing heavy dumbbell forward presses repetitively, and he came in with right shoulder pain. This is a warning to make sure that you have the individual take their shirt off if it's a male, or have some type of a jog bra or some way or to see the scapula very clearly. If you look at his scapula symmetry, there is a definite difference on the right where he has atrophy of his supraspinatus and infraspinatus compared to his normal opposite left side. And he has shoulder pain not emanating from his shoulder, but emanating from a neurologic stretch of the suprascapular nerve involving both infra and supraspinatus. He had EMG, nerve conduction velocities, to document this. And fortunately, with not lifting so heavy and modifying this, after 8 months, he became essentially now symmetric. Let me do that one over.
Sure. And you can see the video over here.
Okay. So that's a different guy. So we need to stop the video before we get to him, yeah.
Just have that.
And I think he does sit-ups, and or he does push-up. I mean, he does dips. We have him doing dips too, so I can watch it from this side. Because I can narrate what he's doing.
Can you see it from over there?
Yeah. This college student came in for shoulder pain, but you can see there is an asymmetry of his scapular musculature, supra and infraspinatus, by the hala that you can see, and it is better seen when we do provocative tests on him, such as manual muscle testing of the deltoid, of the infraspinatus with thumbs up, supraspinatus with a thumbs down. You can see the scapular asymmetry just on testing with the arm in different degrees of rotation. And watch what his scapula does there, and then as it comes back. Significant muscle atrophy of the supraspinatus and infraspinatus. He's still pretty functional. He can do a dip coming all the way up, but look at the asymmetry of how atrophic his musculature of his supra and infraspinatus is on the right. So he came in for shoulder pain, but truly it was his scapula, a C5 suprascapular stretch injury. Have him do push-ups on the wall. This injury occurred when he was doing very heavy forward dumbbell presses repetitively. The next case is a 16-year-old right-hand dominant male who is a football linebacker, baseball athlete. Came in with complaints of left shoulder pain, mainly in the front, for 6 months. He couldn't really remember a specific mechanism of injury. Typically, I would think in a linebacker, front side, and a baseball athlete, maybe you had anterior instability or an anterior labrum tear or slap tear. That would be what my thought would be. These are his initial x-rays. On the axillary lateral view, don't see any evidence of a bony Bankart lesion. His epiphyseal plate is closed. It was difficult to see any abnormalities on this transscapular view. Although he had classic signs and symptoms of a slap tear, imaging was done. I think it's particularly important to get advanced imaging, such as an MRI scan, if there wasn't a specific mechanism of injury to go along with a slap tear. This is his non-dominant side. Typically slap tears occur in the dominant side in a baseball pitcher. So if you look at this MRI scan, you can see a space-occupying lesion in the biceps groove. Seen best here. You don't really see a normal biceps. The biceps is being compressed by this lesion, so here's what's left of his biceps in the groove. This lesion seems to be sitting there. It doesn't seem to be aggressive or permeative or destroying the structures around it, only compressing things. And this is the subscapularis, and his labrum was normal. Beautiful looking labrum. So my diagnosis based on his age was a labrum tear or slap tear, and this is a good example of why advanced imaging is excellent and gives us another piece in the diagnostic puzzle, giving us a diagnosis of a proximal humeral lesion just lateral to the biceps, a space-occupying lesion. We marked him appropriately so we could make an incision directly over the tumor. The thought was this was most likely a chondroblastoma based on the location and the appearance. An excisional biopsy was done. No arthroscopy was done. The labrum was not looked at. He had been marked with IV contrast and CT scan just prior to his excisional biopsy. And these were the findings consistent with chondroblastoma. I'd been looking for one of these throughout my career, and this is the only one that I have seen. And he had a curettage and excisional biopsy of his proximal humeral lesion. This is what the gross specimen looked like. The differential diagnosis of a proximal humeral lesion would be chondroblastoma. Certainly you would think about an infection with a sequestrum, which this patient did not have history consistent with that. Atypical enchondroma, osteoid osteoma, or an osteochondritis dissecans. Lesions that are epiphyseal in location, you have to think about certain things. PGCAT is a good way to remember it. Pigmented villonodular synovitis, giant cell tumor, chondroblastoma, aneurysmal bone cyst, or tuberculosis. So think about those if you have a lesion that is epiphyseal in location and in this age group. The next patient is a 12-year-old soccer athlete. He was right-handed. He had pain in his left shoulder that started about 2 years before I saw him. No injury. His physical exam, he had normal stability, full range of motion, but he did have a palpable, mildly tender axillary mass. Good case to remember to do a physical exam, a thorough physical exam. His plain x-rays were normal. His MRI scan shows an axillary mass that's quite large. These views show a normal glenoid, and the space-occupying lesion is here, so a soft tissue space-occupying lesion. Labrum appears normal, coracoid appears normal, the bone itself all appears normal. This is his axial view. Biceps looks normal. Here's his anterior, inferior space-occupying lesion. He underwent limb salvage with a diagnosis being synovial cell sarcoma. This was followed by chemotherapy, and he too did well with care from the oncologic orthopedic surgeon. This is a young lady who is 12 and a half. She fell onto her right arm, sustaining a humerus fracture. She was put into a sugar tongue splint, and 9 days afterward she fell when she was doing something, walking over a creek, stepping on a log, and broke her left wrist. This is an example of the humerus through a simple bone cyst, and the wrist fracture was when she was doing something that she shouldn't have been doing, so now she has both upper extremities broken. Here is her x-ray. You can see here this diaphyseal location transverse humerus fracture. It's a little hard to see the cyst, but there is some radiolucency here and here. So if you have somebody that develops or comes in with a diaphyseal humerus fracture, oftentimes there will be an underlying unicameral bone cyst. This was her x-ray where she had this fracture and then a week later had a distal radius fracture. In follow-up, you can see the cyst a little bit better. The humerus did go ahead and heal, but it almost looks like the cyst gets a little larger. You would think it would get smaller after a fracture like this, but this was 18 months after her injury. She had absolutely no pain in her arm and had returned to soccer activities. Treatment was immobilization, and she did heal. Further follow-up 3 years after the fracture showed complete filling in of the cyst at 3 years, but it took that long. This is a 15-year-old baseball athlete who was throwing the ball in from outfield and felt his arm follow the ball to the plate, which literally it was trying to do, and he too had a fracture through this unicameral bone cyst. Again, a little hard to see the cyst, but we see the cyst as healing occurs. So he ended up filling this in more quickly than the last patient. But think about a unicameral bone cyst if you have a diaphyseal fracture in an athlete without a significant amount of trauma. I hope these cases will make you think about certain conditions that you may not have thought about before. Remember, you may not have seen it, but it has seen you.